I'm Mike Kelzer. Growing up in my family's pharmacy, life moved fast. There was always something to do, someone to help. But the moments that meant the most to me as I think back were the conversations my dad and I would have about business and life itself. We'd get so absorbed. We'd talk for an hour and it would seem like 15 minutes. This podcast is my way of keeping those memories alive. There's no scripts, no outlines, no fluff, no hidden agendas. It's just real honest talk about the business of pharmacy and sometimes a little more. Let's dive in. Kyle, introduce yourself to our listeners.
My name's Kyle McCormick. I'm the owner of Blueberry Pharmacy, along with my business partner, Ravi Patel, who also works at the University of Pittsburgh School of Pharmacy. We've owned Blueberry Pharmacy for going on 5 years. 2025 will be our 5th year anniversary. But we opened it as a cost-plus model, one of, if not the only one in existence back in 2020. So it's just a pricing philosophy. So the thing that made us a little different would be there probably were other pharmacies back in 2020 that were using cost-plus pricing philosophy, but we weren't involving insurance whatsoever. So our model was completely insurance-free and also using a cost-plus pricing philosophy. I've seen a lot in the independent space, worked for 4 different independent pharmacies before opening up Blueberry Pharmacy, and have now helped pharmacies across the country with membership models, cost-plus models, branding, marketing, all kinds of different things. Also, one of my favorite things about my bio would be that Mark Cuban has called me a troll.
Is it a fair statement?
I think he's not true in how he describes things, but one truth is that I do like to troll him. So,
did he reply himself that you were trolling because he sees you enough?
From the listeners to a reporter, a local Pittsburgh newspaper had our story about the cost-plus model and how we were doing it first back in 2020 and how things that we do differently and actually how it is a true cost-plus model, true insurance-free model. Cuban is a PBM, and they just apply pricing to whether it's other independents in their card network or their 2 mail order fulfillment centers. They just are the price setter, so they're a PBM for those pharmacies. So I was describing that to the local newspaper, and they reached out to Cuban for a comment, and he just apparently refused to comment other than McCormick is a troll.
Dig into that a little bit, Kyle. You say that Cuban's a PBM, but let me ask you, when we first started talking about this years ago, one of the thoughts I had is customers can kind of just come and get prices. I think the beauty of cost plus is that you're able to give this to a whole company and say, trust me. I'm not going to give you different price lists and things like that because customers can find out what the price is, but the companies often don't do that because they're not going to go through every single line item each time. So it's kind of a trust factor. Now, if you're doing that for a company, then you're somewhat the PBM because you're price setting and things like that. So let me go around the back door on this, Kyle. Have you done any of that for companies? Said, hey, you're a local company, you got X thousand people, why are you spending this? We're going to guarantee that we're this much over cost, trust us, and we become your little PBM. But you said that that's a complaint against Cuban's thing.
Yeah, I would say the complaint against Cuban's model is that they launched with the premise of we're eliminating middlemen. And so the difference, though, is they are neither the manufacturer, which they claim to have launched, or the pharmacy fulfillment, which is either Healthy Dine, TruePill, or any of the number of independent pharmacies that take the Team Cuban card. So they only are everything in between.
They turned into a PBM, but they didn't start as a PBM on either of those ends, right?
Right, yeah. So that's my main criticism of Mark Cuban, of Cuban's cost-plus drug. In April of this past year, 2024, we did launch a business B2B offering for our cost-plus model. And so that's where we go to different local businesses and say, hey, no, this isn't insurance. What we're offering you is a basically carve out for generics for your employees. And we can show you line by line how much we'll save you. And so we do have a contract with a local business for that. We have about 73 covered lives as part of that. The difference that I would say would not make us a PBM per se, I think a PBM would be an entity that would network for different multiple locations and whatnot. We're the only pharmacy affiliated with that contract though. And so really we're employees, and their employees also don't have to use us. They're incentivized to use us through, $0 copays on certain things that would be high cost for the employer that they can get lower through us, or just lower costs in general because our costless model is cheaper than their previous insurance copay would have been anyhow. So they still have their insurance. They can use it any pharmacy they want to, but if they want the lowest copays, if they want to save the employer the money, then they can fulfill it at our pharmacy. So we're more of a pharmacy than a PBM in my mind. And maybe that's just me wanting to not have the name PBM associated with.
No, well, I don't blame you.
The more I think about it, your comment about when we talked in the past, isn't this something you could take to an employer? I really just want us to have a free and open marketplace for generic medications. I think if you empower a consumer to act as a consumer in their own healthcare, they can find the best pharmacy at the best price that works for them. And we do some consulting where we do work with other pharmacies that are cost plus pharmacies, but you really don't like the idea of ever creating a network of cost plus pharmacies and then taking that to a bunch of nationwide employers. Like, that's just not my goal, because then you do have to become a PBM. I have to say, if we run a network of cost plus pharmacies, that here's the cost plus rate, right? And that rate may not work well in certain areas as it does in other areas. You can set yours at cost plus 8. I can set mine at cost plus 10. And if a consumer's like, well, I like the service of this cost plus 10 pharmacy better, and that price is agreeable to me, then we just had a free and open marketplace decide that transaction versus an employer and their PBM contract.
They would get then reimbursed from their company, something like that.
Yeah, I think in my ideal world, how cost plus operates is it's an open marketplace for generic drugs. If a employer or a Medicaid plan wants to offer some benefits for generics to their employees or taxpayers or citizens or whatever, they could do it in the form of an HSA, FSA or something like that, or a pay and then get reimbursed type model. Generics are so cheap. We don't do this for Tylenol. I mean, Medicaid does, but outside of that, like FSA, HSA, we just need a payment processing layer. That's all. The tax benefit for medical expenses is the reason that employers do it. And so just when I say offer coverage for generics, because there's not really a reason to. You could just equip somebody with an HSA, FSA and say, hey, go find the pharmacy that works best for you. And that reimbursement model looks very straightforward. They pay with Visa or MasterCard.
And I don't mean to press this point, but there could be something that kicks in at a certain level.
When we're talking generics,
you don't get it with generics.
Yeah, you don't hit it. And even brands, right? If we eliminate rebates from brands, the international prices are kind of what our prices would be if you just eliminated the rebate. Even brands would be affordable. That an FSA, HSA, you just cover that. You just equip them with some money, $2,000 a year to cover all their generics. I just saw that FSAs can cover, 8 sleep mattresses now. And I'm like,
Kyle, we got to unfold some of this stuff. First of all, your beef with Cuban, it's not with what he does, but he leads with the story of we're a manufacturer, we're going to cut costs that way and so on, right?
That was the initial story back in 2021 when they launched.
I had Alex, their CEO, on here, and that was their goal at the time.
Actually, that's a goal that I would applaud them for if they could reshore some manufacturing. Our supply chain is not as flimsy. But I think that they've realized that that's a hard thing to do outside of maybe doing some IV bags for hospitals in shortage and stuff like that. It's actually really hard to compete with generic manufacturing. We have one of the lowest cost generic drug supply chains in the world, cheaper than from developing countries. So you can't outcompete that. I think we're talking, a radiologist enters the pharmacy space and looks and says albendazole is $80 a tablet WAC and $70 a tablet NADAC, and I can make it for the tablet and sell it for $30 a tablet. And that was the premise that they launched on it, and they didn't realize that WAC and NADAC are not actual prices.
Someone's probably even doing it cheaper than their dollar whatever. They just don't see that in the market. All right, so there's one beef with Cuban. They said, we're going to manufacture this, and they don't. The next one is, we're going to help supply this, and they don't because they're not a pharmacy. They use other fulfillment.
Yeah.
Basically, they're a PBM.
Their website, when they launched, says eliminating middlemen, and purely they've become every single middleman.
They're purely the middleman. Now, Kyle, do we still see that everywhere on their stuff? Or can we say, Kyle, hang it up. That was in the past. Now they're this. Or are they still claiming we're going to manufacture and we're going to help this or that? Do you still have a beef with them, or are you just pissed from the past?
Their website does still lead with no middlemen, no price games.
That doesn't sound good because all they are is a middleman then.
Exactly. My only existing beef is, if you've noticed this, all the Mark Cuban commentary has changed to not be anti-PBM. It's been pro-transparent PBM, because they've actually been called out from people like me that they are a PBM. In fact, I think they use RX Sense as their PBM, which actually is a member of PCMA.
Wait a minute. So not only are they not their own pharmacy, they're not even their own PBM. They just set a price for the PBM. So they're nothing.
I don't think they are their own PBM yet. No, they're not their own wholesaler from my understanding. I think they use Graphite for that, which is just an amalgamation of things like TopRx and things like that. So they're an aggregator under a marketing. They're a marketing company is what they are. But Mark Cuban made as marketing for many different entities.
So what they're doing basically is they're coming in as a smaller, more nimble price setter. But as soon as they get the numbers, and we always talk about the big three PBMs, if they ever got the numbers and took, 3% of that or something like that, that's big money. And then they can start pushing people around like anybody else can because of their numbers.
A couple of things I do give them credit for is, one, they've brought a lot of publicity to the pharmacy space. Prior to Mark Cuban, there was very little talk in the media about it. I think it was naturally going to happen, maybe not to the scale that it did, just because of how dire things had gone. And then the other big thing is that, they do listen to pharmacy, even from the beginning, Alex Ochmiansky talking to myself, talking to you, learning that drug pricing is the problem, not manufacturing. Learning that their initial was cost plus, I believe, $5 for their Team Cuban card, and that $5 is not going to cut it for most independent pharmacies. Then they moved it $8, and I might be getting these numbers wrong, but I think it's now up to $12. So unlike most PBMs that don't listen, is that something that would stay with them long term? I think that over time, they're probably a better PBM than nearly any PBM out there. But I think my biggest beef with it is that they're doing it under the premise of not being a middleman or a PBM whenever that's what they are.
Well, Kyle, now this isn't your only beef with them, because now I'm thinking back to your other posts here as I think back on LinkedIn. I think you had one saying that, their X dollar shipping is per bottle, per vial versus per shipment.
Yeah, I think that was...
That wasn't true? You were just making up trolling then, or what?
I wasn't purposely making something up. It was unclear on their website. I've not touted that since maybe a couple weeks into their launch, just because on their website, they used to explicitly say, we won't transfer prescriptions. Now they will transfer prescriptions. So they've been called out on a lot of this is a faux pas in the space. I think it might have been initially $5 per shipment, but yeah, no, that's not the case anymore.
You're not saying you're just reposting it.
No, I haven't reposted that in a while. The thing that you might have seen recently is the cut of transaction that Mark Cuban takes. It's a 15% cut of the transaction, which works out to be more than the pharmacy dispense fee in most cases. So if you think of one of the top drugs in the cost plus space is probably abiraterone, which is about a $100 drug. And so the PBM, Mark Cuban, or whatever you want to call it, is taking 15%, that's $15. Whereas the amount to the independent pharmacies, 12, the amount to Healthdyne / TruePill is 5. So in that transaction, Cuban's making 3 times the amount of the pharmacies fulfilling a mail order, and $3 more than the independent pharmacy. And what have they done in that transaction, right? They're just a website that people have gone to. A percentage-based model for a PBM is a lot like we call out other PBMs for, because you're really not aligned to get the lowest price for patients at that point. And this is something that AJ Loyakin of Capital RX talks about a lot is, percentages are really bad misalignments to do anything within healthcare, because then you're looking to increase the cost of care because you get to cut over that. So that's why we don't like fee for service, but really a dispensing fee or an administrative fee, which is what Capital RX uses, is the most logical way, and probably you could argue the most ethical way of actually handling costs in healthcare.
I've had AJ on a couple times. I saw one of AJ's posts last week basically saying you should not make money on the drug. It shouldn't, just what you were saying there about it.
You should not make money on, the drug. I think to counter the Visa MasterCard, I think that they're taking a capital risk. So it is a proportional to the amount spent.
When they guarantee.
So I think it's a guarantee on that. Whereas our PBM, no, I mean, there's money from the employers, ACH. It's not the money is not the risk. It's going to be paid out. There's not going to be fraud. There's not going to be, they don't need a percentage base. It's an administrative thing.
All right. So Kyle, you get your chance to bitch about Cuban. I know that you're very involved with education and interns and things like that. And I get to bitch about people that I have to teach. I just hate teaching. This isn't teaching because the podcast listeners hear it, but I don't redo it. It's heard in perpetuity, but I'm not doing it each time. I'm just griping about something once and then moving on. But I hate, sometimes I would have to hire a few people in a week when a few people quit because they're pissed at me or something. So I had to hire a few in a row, and I hated that. I just hate teaching, but you don't mind it.
No, I love teaching. Yeah, I think it's partly my mom was a first grade teacher. She's now retired. Probably one of the hardest, I would imagine, ages to teach. That truly isn't teaching. It's like more like corralling and herding.
Well, you say that, but my son is a high school English teacher, and sometimes that's the same case, unfortunately, these days.
Yeah, one, because they're either checked out, because they're 12th graders, are probably half of them are checked out. And then on the first grade, they're checked out because their brains are off in other worlds.
What do you find in teaching you like? Is it the aha that shows up on the people's faces? I don't get it. I don't see what you could like in teaching. So what do you like about it?
I think it's the fresh perspectives. I often say that I learn just as much from students as they learn from me.
From them. You're getting it from them because they know all the newfangled stuff and all that.
Yeah, and they hold me accountable to keeping up to date with things. I think if I wasn't teaching and reflecting on stuff, I would probably not know some of the latest literature.
Yeah.
Recent examples was somebody, this is embarrassing almost to put out into the world, but I know that other people don't know it, so I'll share it, is that I didn't realize rosuvastatin should be renally dosed. So
I don't even know what the hell that even meant. No, I know. Yeah. Rosuvastatin, I see that a lot. What drug is that?
Crestor.
But we can't talk about that here. No medicine names on here, Kyle. See, you're off in your teaching mode. We can't do that here.
So just the fresh perspectives, the keeping up to date, but it's really, I think a lot of teaching is looked at with just rote memorization or just completing assignments. I often say to students, my goal isn't for you to just check boxes. One of the assignments I have them do is basically come up with one improvement to the pharmacy or patient experience. Your 5 weeks here, come up with something to improve it, and we'll actually implement it. And the one student most recently was like, how many of these do you actually implement? And I was like, we try to implement them all. But some of the best improvements to our workflows or our patient-facing messaging or, even physical things that we have here in the pharmacy are purely out of students saying, hey, I think this is a better way to do. So yeah, it's just a fun way to engage each other. And I think we all learn by doing so.
So here's what I do, Kyle, with students. I do it with my kids, actually. I'll be saying something, and as soon as I find out they're smarter than me, you just pretend like it was a given, like, well, yeah, of course, that. I didn't mention that, but I'm at a deeper level right now. Kyle, you mentioned George Zorich on the show. George is one of my favorite guests because he's got a lot of opinions. He's very opinionated. You've heard me gripe a couple times about college length being too long and a money grab and all that. What's your take on that?
Yeah, and all my academic friends and colleagues probably shouldn't listen to this podcast.
Just like the way their pharmacy owners shouldn't have listened to me saying, let's take a look at importing stuff from Israel,
But yeah, I think that we over-credentialize and that a lot of pharmacy could be an apprenticeship. And I think that you kind of hit that with George's podcast as well. But if I think back to several students that come through rotation are like, I've learned more here in the last 5 weeks than I learned about community pharmacy in 6 years. Like, what kind of statement is that? I don't think we're doing anything super exceptional here. It's very basic stuff. And so the fact that they feel like that's more than they learned about community pharmacy, and just even about Medicare rotation, where we teach about reimbursement. And I often say the pharmacy calculations that's not taught is about the math related to DIR fees, GER fees, BER fees, reimbursements. Like, how do you actually make a paycheck in pharmacy? That's an important thing that students should understand how that works. There's certain like fundamentals of pharmacy that are often shied away from. And I think that's important. And also, there's a lot to be learned about drugs just by being and practicing and counseling patients. I think one of the biggest, in the state of Pennsylvania at least, the biggest things over the past 5 years that I would say hurt education was actually removing the hours requirement for interns. I think back to my intern experience, 1,500 hours, I think 750 of them had to be on my own. I had to go out and acquire those hours. Had I not done that, it's one thing to learn about amlodipine in class, Norvasc, but it's another thing to have like filled it every day and looked at it and said, I wonder what this is for, and start blood pressure. Okay. And I see that they're also usually on hydrochlorothiazide and maybe lisinopril. All these things I just pick up just by filling the medication and just by interacting with patients about their medications. And then I can go learn the theory of it in classroom of here's how actually a calcium channel blocker works. But all that baseline knowledge I gained purely through internship. And then I actually had the fundamentals of how it's a calcium channel blocker drilled into me in the classroom. But I think if we look at NAPLEX scores or even just overall sentiment of how colleges are doing and students are doing, I think some of that has to do with the fact that we got away from that in the field learning experience.
And I think that they maybe could argue, they being the schools, could maybe argue and say, well, who's opening an independent? Why do they have to learn that? And the answer to that is, well, yeah, maybe there, but how about entrepreneurial pursuits from a pharmacy student? I mean, what a better way to teach that? Think of it as a little lemonade stand size, and that's how you teach the bigger concepts of business. And so, yeah, that's missing.
You think about leading measures and lagging measures. Well, leading measures often in academia are like NAPLEX scores and progression along this scale. What's the overarching goal of outputting pharmacists? Is it to create new realms for pharmacists to practice in? And if that's the case, one of our best metrics for a school of pharmacy should be how many entrepreneurs did we put into the world? Like how many new businesses were open? How many of our alumni are owners of their own business? Nothing against people who want to work for other people, but I think the entrepreneurism has definitely left the field of pharmacy.
You get a profession where nearly everyone coming out is going to follow.
Mm-hmm.
And my beef about pharmacists is that even somebody with a crap load of degrees behind their name, you're still kind of, I hope no one listens to this. It's just you and I here, Kyle, so I'm going to say it. You're kind of kissing up to the doctor. I mean, they still are putting their stamp on everything. So here you've gone to school for 8 years and you're not really doing something without clearance. And people will say, well, no, you give these rates and this and this and that. It's like, yeah, but it still has to go through somebody. And so my thought is you get a program that is basically all employees, not too many employers. And then you get a profession too that what decisions are they really making? And you're creating a world of followers. And how long can the profession do that? And that's a bold statement. I don't stand behind that completely because, I don't know, I just spouting off here. But when you think about it, can you have a full profession based on following? I don't know if you can or not.
Yeah, I think what I've often been saying now about the academia is pharmacy especially has to identify what is a pharmacist, what is pharmacy. Because I think a lot of students will ask, a lot of peers will ask, what kind of clinical services are you doing? And are you doing point of care testing? Are you doing vaccines, all this stuff? And I'm like, well, if I look at what a pharmacist is licensed uniquely to do, a lot of times in a lot of states, it's our unique license. What makes us unique is making sure medication is safe and effective for a patient. If we want to have more of that clinical aspect, I think pharmacy schools would actually be better off dual degreeing PharmD. I think why not PharmD and NP, PharmD PA. You're equipping somebody to either go out and dispense and or prescribe in that scenario. Why are we fighting for prescriber status or provider status whenever we could just go and re-credential as NPs or PAs? But I think it's because we're afraid of tying ourselves to the product, but I have nothing wrong with that. We know more about drugs than any other profession does. Why don't we own into that and redefine the dispensing process to not be just putting pills in a bottle, but actually having meaningful conversations about whether or not medications are safe and effective for patients. And I love the checks and balances. The beauty of our government has checks and balances. And I think that if we give pharmacists prescriptive authority and too much to any extent, then we lose that check and balance. And so I think that a lot of, in my mind, the education in general should be, what are our goal outcomes? What do we want the professional pharmacy to be? And if it is more of that clinical sense, then why aren't we dual degreeing with other degrees that already have those abilities? Why are we recreating something within the PharmD degree?
I'm right with you on that. You teach people something that the world needs. You don't teach it hoping the world's going to need it because you have more degrees. And I'm the same way with all that stuff. I mean, some people can call me lazy, but I say to my kids, hey, listen, I'm not a triage nurse. I'm not a vaccinator. I'm not all this stuff. You know, I'm product-based and safety-based and so on. And if that's only a 1-year program in college and you take a year of that and, 3 years of PA or whatever, then so be it. But let's not make this into something more than it is. And with that said, there's 5% of the people that need everything that's being taught to them right now, but 90% of them, 95% of them don't need it.
I don't think there's even 5% that need everything.
All right, I'm being generous, but you know what I mean. There's a
right.
certain percentage that's doing this,
Right?
And I've determined in my mind, it's money. It's keeping the system going. It's building the new rec center and the pool and the this and that for the colleges. But what's it doing? I mean, where's the end of this?
Yeah, even vaccines, I think, is a great example of that. It's like pharmacists should be vaccinators. Back whenever pharmacists got that, it was a rallying cry, and that was going to allow us to take these appointment-based things that people don't get and just give it right to them whenever they're picking up their prescriptions. And
Yeah.
we look to what we've created now, it's appointment-based. And it's not even done by a pharmacist. The higher volume places that do vaccines, they're hiring PAs and nurses and having pharm techs do it. So it's like what we were rallying and crying for pharmacists to do, we've now realized is below a pharmacist.
It's just like, there you go. It is below a pharmacist. You don't need 8 years to stick something in someone's arm.
It just doesn't fit in workflow. It really doesn't. The reality was that it pulled a pharmacist out every 15 minutes, pulling them out from their focus of dispensing it. Then we had other people do it. So does it fit in a pharmacy? Yeah, sure. You can do it in a pharmacy, but does it have to be done by a pharmacist? No. So do we need to teach it in pharmacy school? Should be apprenticeship.
So Kyle, what does the curriculum and the number of years look like for someone coming out of high school? If you had to come up with a tight, newfangled system where you're going to teach pharmacists for what they need to know, and it's going to be one of these, Google things where it's so many months, and you've seen them for coding and things like that. So pretend you're in the shoes of a company like that is going to make this as tight as it can, but do it that is still a good service to the community. What does it look like? What's that going to look like?
Oh, it's definitely a 4-year degree or less.
2 years redoing everything that was done in high school? Or do you mean
No.
if that was out of there, would it just be 2 years total?
Yeah, pharmacy itself could be 2 years.
Let's say somebody comes out of high school and they know everything there is to know, at least at that level, about history and, English and all that kind of stuff. Don't do that in college, and let's make pharmacy a 2-year degree. So you could have people coming out of pharmacy school when they're 20, basically.
Yeah, what's like an apprenticeship component of it?
Maybe after that.
No, during.
Oh, during.
Apply it as you're doing it.
2 years total.
Yeah.
Pharmacy schools are not going to be a fan of you.
Many people aren't fans of me already. So.
Don't worry about Cuban. Just don't worry about that,
No,
Kyle.
I'm not worried about Cuban. No.
Who else isn't a fan of yours?
People that make money under the existing model, especially pharmacies, even some of our peers who think that it shouldn't change, that insurance is the way of the future. And
You know me, Kyle. You said 3 years ago, you said, hey, Mike, you're not doing brand names. Why are you doing insurance still? As I haven't changed that. I'm still doing insurances.
why are you still doing insurance?
Partly, I don't have much time left. I'm not dying. I mean, I've got only so many years left in pharmacy. Well, I am dying, but not at a rate that anybody would be concerned about. We're all dying. But why don't I? I don't know. It's like we've made moves. We've got, volume things. And like we had someone come in last week and she said, hey, I'm sorry I got to leave you after all these years. And the guy on my team said, well, why? Who are you with? Well, we're with such and such. Oh, well, we can do so many for this and that. And besides it not hitting your deductible, because here we are at the end of the year and your deductible has not been met. So we're picking up customers with non-insurance stuff. I don't know if I would just say to all of our customers, like, we're not taking your insurance anymore, because if I could maybe sit down with all of them, not me, but somebody who knows what they're talking about, if you could sit down with all of them and say, hey, here's how you can do this and stay with us. Well, maybe we'd pick up 70% of those people, but I don't have that faith in our skills that I would just say to somebody, once you're already set up, we're just not doing it, period, anymore. It would take a lot of marketing and a lot of proactive thinking.
Yeah, and a lot of what I'm going to say or ask is Medicaid aside, because I think Medicaid reform has to happen anyhow, because it is an important component, but I think the insurance-based model for that is going to stay in place for some time at least. Have you ever run the calculations in terms of patients with copays? What percentage of those are the full amount paid to you?
I haven't, but you're saying that if it is a full amount,
You're basically already insurance free.
you're already doing it.
Yeah.
And you could probably save on money on top of that.
Yeah. Some people have analyzed that and things with copays. I think Medicaid aside, and then not $0 copays, obviously. So things with copays, like 80%, like that's basically your full reimbursed amount. No, that's on the high end. And then the other thing to look at too is, of those patients, what percentage of your actual claims are filled above your cost to dispense? And so in a lot of stores, that's say below 20%, 40%. And so you're basically not making enough money to dispense products 70 to 80% of the time. And so you're relying on the last 20 to 30% of claims to actually make up the difference. So you're worried about losing some patients and whatnot. You can actually run a sustainable pharmacy with less patients because you've eliminated a decent number or moved over a decent number of patients who were previously costing you. And I think back to your comment podcast as well, maybe it was with me, but I think it was actually with somebody else, who you were worried about, Mrs. Smith, who I think this was why you got rid of brands, where you were losing money on the brand and you started to be like, in the back of your head, I don't have much time to spend with you because I don't make money on your prescription. And they had this like thought experiment, like I need to care for everybody equally. I can't not like my patients that are on Eliquis just because they're on Eliquis. But in reality, that's happening not on a loss per se, but I make more money, which already happens in pharmacies. I make more money on shots, so I'm just going to focus heavily on shots. And I don't spend any time counseling somebody on their metformin because I make pennies on that.
To your point, Kyle, in a way, we've done that with brand names. It's like we're not carrying brand names. We could have switched all those brand name people over to cash. I mean, we couldn't and still have it in the store contractually and all that kind of stuff. But in essence, with the brand names, we said, we're not using insurance. Officially, we took them out of the store, but in essence, it's like, we're not going to bill your insurance for that too. That's a big part of it. But are we selling for a loss? What is the full amount that they're not even touching? And I agree, it's probably a lot. It would almost be a sit down with each person to explain it to them versus just not doing it at this point. Because if I'm confused on it, a lot of people are.
Yeah, a lot of patients will ask. They'll get referred to us because of cost savings and whatnot. They'll say, that's only $13 here. They're like, wow. And do you need my insurance card? And I was like, no, that's our price here. And so they get all concerned then, well, surely you need the insurance card though to bill it. And they're like, no, that's just our price. Well, how come it was X amount more elsewhere? And so we've actually learned to just basically avoid the whole insurance conversation altogether. But what I mean by that is whenever patients get referred here, we just tell them the price. And if they say something like, do you need my insurance card? We just say no, versus like, we don't bill your insurance here or anything like that. This is our price. The price is the same for everybody. But a lot of patients want to feel heard. They have insurance. So they'll say, oh, I have insurance. And we just say, that's great.
Don't have the whole long conversation with them. People don't care. They just want to know if you need it or not, and they're happy with the price.
We're afraid to talk prices with patients as a profession. One of my newest challenges to students is to tell me how much they think they're worth. When you start talking to students, you say, well, if you're going to do an hour-long CMR, how much are you going to charge them? Well, you're going to say like $50. And I'm like, well, how are you going to pay yourself this hourly salary that you would like on $50? And then not only that, but your employer has to make money and profit on top of that. But your technician might be doing work that doesn't directly, they might be scheduling those CMRs or doing something that doesn't direct revenue. So you've got to account for that, your technician's salary as well, in that hourly rate. So at the end of the day, you got to be charging $120 an hour. And they're like, well, I can't do that. I'm like, well, why not? And a lot of students will say, I wouldn't pay that. But it sounds like you have a bad product. So then I challenge them, well, why is it a bad product? It's because it's a 20-page document that nobody ever reads. It's a medication action plan that they have to follow up with themselves that you don't do any follow-up with the physician with. It's done on your schedule, not theirs. It's you cold calling them in the middle of the day saying, hey, let's talk about your meds because your insurance told us to. It's not them coming into the pharmacy with a list of questions that you answer. So there's a lot of ways to make the product better. And so I think we're really bad about talking about prices in pharmacy. We're afraid of assigning value to ourselves, assigning value to what we do, even to where a lot of pharmacies don't think about, oh, how much should our cost plus be? It's like, how much do you need to make on each prescription in order to make a profit? How much is the cost, the value of dispensing? How much is that worth? Even to the extent of like clinical questions. Do you charge if somebody, if Mrs. Smith comes in with a question? And we actually do. We charge for coupon navigation fees for our patients. There's, even if it's something we don't fill at our pharmacy, if we're able to help the patient get it lower cost at another pharmacy and coordinate that care for them, we charge for that service. One of our last students, his first day here, he was a little shocked. We said, if you want to figure it out on your own, just go Google. I don't know I doubt it was Ozempic. It was probably like Entresto or something like that. Google it and follow up with the other pharmacy. Or if you want us to take care of it for you, it's going to take us about 10 minutes. We charge $20 for 10 minutes. We'll get that coordinated. So we said, we're going to get you EpiPen for $15. So we said, well, let's coordinate everything with your other pharmacy and we'll get it reduced to just $15 and probably take 10 minutes. So it'll be $20 for us if we do that. Like, oh, I'll just pay you $20, go ahead. And so we coordinate the whole coupon service, help the other pharmacy, have them apply the coupon, make sure it actually adjudicates to $15. Oh, the patient say, hey, it's ready for pickup, it's $15, and give us your credit card because that was a $20 coupon navigation fee. And the student was like shocked. I used to work at Rite Aid and patients have cost issues. We just throw up our hands and say, there's nothing that we can do. And here you are like actually doing things and charging for it on top. So like, yeah, you have to have a price and patients are willing to pay for your service if you have a line item for that service.
In the years before COVID, we were wasting a lot of money at our pharmacy through DIRs. I had too much staff. We were just losing money. And on top of that, I had lost my faith in pharmacy as far as, well, why are we doing this? I mean, they're paying us a nickel. What are we worth? And so I happened to go back during COVID. It wasn't because of COVID, but that's when I thinned out the staff. And I went back and I thought, holy smoke, what the hell would these people do without me? The stuff at our store, the stuff we were doing. You'd go in and find this lady flat on the ground, dead for 72 hours if it wasn't for the things we have done, whether it's answering something or even the medicine. If we let all these people just out on their own, these people would really die. I think the problem with that, though, is like, how do you prove that? What's the cost on that? If they call you one time and you say, hey, let's put easy open caps on your bottle, that's a nickel. But if you do something else, it might be worth $50,000 because you saved their life or kept them out of the ER, things like that. I think the trick, though, for me would be, where is that in the process and how do you get money for it? And if you don't get money for it, are you going to let them die? And if you're not going to let them die, you're going to save them anyways, then why should anybody pay you for it?
I think that it's not wrong to refuse service for no payment. I think it's actually more harmful to do the other thing, is always give stuff away for free.
I don't have any problem letting her die. I have no problem with that. It's not my responsibility to make sure all these people live. My problem is I'm already stuck in this contract. I can't divide it. I can't drop some people, this and that. So I agree completely. You should get paid or else you lose the pride of that and so on. And the person is going to be lying there dead. I don't really have a problem with that. It's just I don't know how to get paid when I do save them a lot.
I think it's having a set procedure such that when people are asking questions that are above and beyond a over 90 counseling session, we counsel on every single prescription as part of our cost plus dispensing fee. Though whenever it's above and beyond that, because it's about other drugs that we don't fill, it's because it's about a long tangential question about their disease state or whatever, we say, that's a great question. In order to provide you with the best answer, to make sure that it's fully researched based on your past medical history, other medications that we don't dispense here, et cetera, it's going to take time. And we do offer the service where we sit down with you, go over those questions. It's just going to be $20 for 10 minutes. The question you asked probably would only take 15 minutes of time. So you'd be looking at a $30 copay for that. Is that okay with you?
That can be done on top of any insurance contract because you can just say that's an extra service.
Right, exactly.
I know we're not talking insurance with you, but I mean in general.
I actually piloted this concept with my previous pharmacy where I was at a pharmacy in Indiana, Pennsylvania. And the one that sticks out to me was a patient called from the aisles of Walmart saying, hey, I wanted to make sure this medication wouldn't interact with anything I'm taking. And I said, we don't fill anything here for you. Like, why are you calling me? It's because trust you. I heard good things about your pharmacy and I had this question. I said, well, I'd be happy to help you with this, but our time is valuable. And also we're 6-year degreed professional. That's how I'm able to answer this question safely for you. And it also requires some time in making sure that I understand what all you take and what the product in your hand at Walmart actually is so that I can tell you about it. And so I have to charge you for that. Now, back then I wasn't charging $20 for 10 minutes. I said, it'll just be $5 consult. And the patient was like, yeah, that's perfect. I'll go ahead and pay it. And so I just took credit card information over the phone, rang about $5 fee. From then on, I wasn't afraid to start charging patients for my clinical knowledge. To your question about if I don't answer the question, this patient might die, that's a reality, but probably less than 0.001% of the time will me not answering the question actually correlate with that.
Let me think about this, Kyle. So I said, if I don't do this for the person, they're going to die. And I'm okay with that. My point is, I'm going to probably do that anyways because I do that for everybody in that pharmacy benefit manager group. I do it for them. And let's see. So if I don't do something extra for them, they're going to die and I have to charge them for that. I'm good with that. I think my point I was trying to make is I don't know what is saving them. I don't know what is not having them die. It's hundreds of things we do for the person. I don't know which one is making them not die, but I know the 100 things we do, they're not lying on their floor dead. I just don't know which one it is. And if I did, I would charge for it, I suppose. Here's the thing. There's hundreds of things we do for a patient, and the little things that we do, almost nobody would pay more than $1 or $2. I can't read that last digit. What is that? Or what's the imprint on this tablet? It's too dark for me to see. Or hold on, my phone's out of batteries. Can you call me back in 20 minutes? This kind of stuff. All right. There's hundreds of these. And I can't put on something. I can't say, all right, it's $29 to read that tablet score, because nobody's going to pay for it. Maybe somebody would, but in general, it's too small even for you to charge for it. But across the board then, out of those 100 things, that's the reason they're not lying on the floor dead. But I can't price any of those 100 things appropriately. And maybe that comes down to then a fee, a subscription to even deal with me. But on an individual basis, it's not going to work because none of them are worth a dime. But altogether, they're going to die if I don't help them.
This is the beauty of a membership model.
And you have that.
Yeah, we have a membership model.
Why the hell didn't you tell me that a half hour ago? We wouldn't have to have this conversation. I forgot about that.
That's the way you raised the question. It's a lot better.
I forgot about that.
This is the beauty of a hybrid model where I'm a big proponent of fee per service, but you're kind of right in that, like, there's a set amount just to have a patient be part of your patient profile. There's like a set cost associated with just having a patient be a patient at your pharmacy. So the fee for service doesn't account for that, whereas a membership model does. So I truly believe the best model for pharmacy is a membership model paired with fee for service. What I mean by that, in our hybrid model, we do cost plus 10 for non-members and cost plus 3 for members. So it's a $7 savings per prescription of markup. But in exchange, it's a $60 per year membership. And so what that essentially is saying, we're going to front load the cost of caring for this patient. I get it $60 today, but every future fill, we now charge less because I know a lot more about that patient. And I'm getting paid for the filling, the little things that we do on a daily basis for patients, for members, that I otherwise have no way of getting payment for. And so that's the idea of the membership model. And I think every pharmacy should have a membership model. It realizes nearly every incentive with the patient. If you think about membership model for patients, currently in a fee-for-service model, I only make money whenever I'm filling prescriptions, aka the more prescriptions I fill, the more money I make, aka the more healthy my patients are, the more money I make. Well, that doesn't sound great for actually changing and being impactful as a pharmacist and reducing health burdens for patients. So the only way to do that is to either charge some kind of deprescribing fee or have a membership model such that the more I can optimize your care, the more I can get you on the right medications at the right time, the more I can synchronize your medication so you're not making as many trips here, the more money I actually make because I get more profit from your membership then because I'm doing less work. And less work actually now correlates to you being healthier and happier. And so the membership model it truly helps to realign healthcare. Now you still need a fee for service there. Otherwise, your membership model just gets filled up with high utilizers that are saving a ton of money because they don't have any kind of cost tied to utilization. But we really have to have a cost tied to some kind of utilization. Otherwise, we'll just get bogged down with tons of questions and whatnot and high burden patients. So that's why you still need that fee for service associated with it. But basically, the answer to your question is a membership model.
I think you're right. Well, damn it, Kyle, now we're out of time. You should have brought that up in the first 10 minutes. So Kyle, you and I now, this is our third time, I believe, and we kind of talked at the beginning and then a year or two into it, now another couple years. How are we doing on things?
Yeah, every year is a record year. And I say that from a couple of perspectives, and that script count has, I think this year we're up almost 100% year over year from the number of scripts we're doing. We're now over 1,000 direct paying members, but we also now have business members. We now have direct primary care members that are, basically doctors paying for their patients to be members at our pharmacy. We're now over on target for about $1.2 million in revenue this year, 40% gross profit margins. We now have a full-time pharmacist, a full-time technician. I think the business model is proving to be a viable business model. The biggest question we get from peers is like, well, is it profitable yet? Are you profitable? I used to get so annoyed by that question. We're like, we're a year into business. Like, it took Amazon 20 years to be profitable. now we are 4 years, 5 years in the business, and I can soundly say that it is a profitable business. All along, I felt that it is the most likely to be profitable because we actually can control our profit margins, unlike any other form of pharmacy business. And I think things like the membership and all that being actually recurring revenue and all that. And so I encourage pharmacies to really think about, I know we talked a little bit about insurance and being afraid to say no to contracts and whatnot, is we really have to stand up for what the value of our profession is. And if we're not able to do that, then other people dictate it for us. And some of it is a leap of faith, but also staying status quo is a leap of faith, because you're basically putting the direction of your business in the hands of others, whether that be the PBM, the legislators, et cetera. And so by saying no to things, it's actually putting the business in your hands, which is actually probably people's biggest fears. To say, I'll allow legislators, I think that they'll make change. Alina Khan's doing great things. Eventually something will come of it. The reality is that the only person that cares about your business is you. And Gary, that's Gary. We want other people to care, but nobody will care as much about your business as you will. I've been screaming it through the rooftops that cost plus is the future. Insurance free is the future for generic marketplace. Drugs will be bought and sold in an open, transparent marketplace. You already hit on this with your guest, IO Meds. Brand names being bought in a transparent marketplace. This isn't just generics anymore. This is a full-on move towards, we actually can achieve lower cost care, better care. You highlighted it with the IO Meds people, how going insurance free, just like we've noticed, we have all 5 stars on all social media platforms. We have more time to spend with patients because we don't have to spend 30 to 40% of our day on phone calls with insurance companies, answering, why is this prior auth? Why is that prior auth? Doctors' offices love us because we tell them there is no such thing as prior authorizations in our world. Basically, every frustration that comes from being a pharmacist, I can tie to being a pharmacist in a PBM-based model. Once you eliminate the PBM, there's basically no frustrations anymore in the pharmacy space, other than the only frustration is hearing, well, I could get that for zero somewhere else. And they're like, well, my biggest competition right now is pharmacies willing to accept losses, pharmacies willing to accept reimbursement that doesn't value them as a professional. That's my competition right now. My competition isn't Optum or Rush Scripts. Honestly, they're the best marketers for my business because of how greedy and how incompetent they are at providing patient care. My biggest competition is pharmacies accepting the status quo.
Golly, Kyle, fantastic information. I can't imagine somebody listening to this and not wanting to check some of this out. Blueberrypharmacy.com is your pharmacy. costpluspharmacies.com is a way for pharmacies to go in and build their special link and have their own price list and so on. Kyle, fun hanging out again. I know you're busy. Thanks for your time.
You bet.
I appreciate it. The listeners appreciate it. Great having you on.
I look forward to talking to you sometime around the 52nd anniversary of the Kelzer family turkey poll.
We do a family football game. If you're interested, go on YouTube, just look up my last name and look up football. You'll see our 50-year tradition of tapped football. That was fun this year. Thanks for mentioning that.
Great family tradition. Keep it up, and look forward to talking to you in the future.
All right, Kyle. We'll talk soon.
Take care, Mike.
You've been listening to the Business of Pharmacy podcast with me, your host, Mike Kelzer. Please subscribe for all future episodes.